Okay. So, hello everyone. Welcome to the UU Virtual Roundtable. My name is Sarah Reyes, and I'll be today's moderator. Just a couple of things before we get started. So today we have Derrick Cuenca, and he's going to be talking about basically running a hospital during COVID-19 and the challenges and changes that come with it. And so before we get into that, friendly reminder that we will be recording these and uploading these onto the UUCLC YouTube page. So if you miss it or you want to remember it, or you know someone who wasn't able to attend, we'll be sending out an email tomorrow that'll have a link for that. So we'll be sending those out every Monday. And secondly, I don't think this will be a problem, but I just want to say it just in case. If we're going through like kind of a presentation and there's a lot of talking, just make sure to stay muted, and we'll have a bit of a Q&A section afterwards. And it's just so that we don't get, a little derailed on the conversation. So if, you're invited to ask a question, feel free to. Otherwise, then I think, just waiting until the Q&A section will be good. And with that, you can take over, Derrick.
Sure. Well, thank you for the opportunity to talk to you today. I got a brief presentation because I know the topic is COVID, right? We want to talk about COVID. Everybody wants to talk about COVID and how we're dealing with it. So a little self-serving in this initial presentation because it's about the hospital and the healthcare network of what MountainView is. So self-serving, but it's also important to understand the network of the health system within our community before we really get into COVID and how we address it as a health system, not only as MountainView, but also as our role with other hospitals within our region. So a little bit about MountainView, and then I got to figure out how to control my presentation because, nope, let me get to it. I'm sorry. I think I'd have it locked in with technology, but I don't. So MountainView is a network consisting of not just the regional medical center, but also MountainView Medical Group, which consists of a number of doctors. Our network is expansive, and today it's in excess of over 1,500 employees, $100 million in payroll, $11 million in taxes. We see over 50,000 ER visits a year, 15,000 surgeries, 10,000 inpatient admissions, and we're spread out over 24 locations with over 38 clinics serving the region. With that delivery system consists of walk-in clinics, urgent care clinics, emergency care, trauma services, primary care services, outpatient specialty clinics, inpatient services, up to and including rehabilitation. So a fairly comprehensive organization. The front door of our hospital, and really any hospital when you think about it, really is truly its emergency rooms. With over 50,000 people entering those doors on an annual basis, that is how a lot of people do end up accessing the delivery system for emergent or acute care needs. We do actually have 2 ERs, one located on our campus, which is 21 beds, and then we are the region's only level 3 trauma center for Los Cruces. We do have a freestanding emergency room, which offers emergency room services up on the north end of our town, off of the main. It is a 10-bed emergency room, and it is staffed by a doctor 24/7, 365. Some of the key services, we offer a full complement of surgical services for general surgery, neurosurgery, plastic, reconstructive, bariatrics, gastroenterology, endocrinology, which is really how we talk about metabolic disease as a whole and keeping people healthy. In addition to the full complement of orthopedics, from joint replacement to sports medicine, hand surgery, physical medicine, podiatry, up to and including the delivery of therapy to get people back up on their feet. We do also have robotically assisted joint replacement program, which is helps with the minimally invasive component of when it comes to joint replacement for those that qualify. In addition, cardiovascular services, we offer a full complement of heart and vascular program, which is complemented by a hybrid OR. It's the only hybrid operating room which offers the ability to do minimally invasive vascular and cardiac procedures. We're the only hybrid operating room in the region. And we have 2 cath labs: cardiac imaging, cardiology, interventional cardiology, electrophysiology procedures, vascular surgery, as well as open heart. We have an open heart program up to and including a robotic assisted open heart program. Uh, some of our specialty lines beyond that include labor and delivery, NICU, OBGYN, pulmonary medicine, urology, and wound care. We actually broke our record for deliveries in the hospital just a couple of months ago with 159 deliveries delivered just a couple of months ago. Outpatient services, full complement from laboratory services, the 6 locations, imaging services, therapy, sleep lab, infusion services, cardiac rehab, and infusion for oncology patients. Just to cap off, what we do provide in the hospital setting. So, and then accreditation. We are fully accredited and put a tremendous amount of focus on quality. Our motto is if we're going to do something, we're going to do it at the highest level of quality that we can possibly do. So we are accredited for our various programs, from national accreditations through either Joint Commission, New Mexico Department of Health, for trauma, chest pain accreditation, bariatric programs. We're a baby-friendly hospital, as well as our sleep labs also accredited. However, when we think about quality, it's not just about the process in which we perform it and the things that are expected on how we perform procedures, but it's also about listening to our patients. We actually have a program, it's called the Patient Family Advisory Council, where we invite patients back to us. Well, it used to be in person. It's not in person anymore. But once patients have been visiting with us, they've been under our care. After a couple of weeks, we call them up and say, hey, would you like to talk to us about your experience? And we listen to them if they're willing to share about their experience. What went right, what went wrong, what could have been better. It gives us an opportunity as a team to change the way we're doing things, or change the way we're presenting ourselves, or provide feedback to our healthcare team. So hopefully that we can provide an optimal experience for patients in the future if we got anything wrong. This has been very challenging amidst COVID. We still do our advisory councils, but they're done like we're doing now, electronically and remotely. It's presented some challenges, as well as restricting the visitation in our hospital we've gotten a lot of feedback on how we can make that better. Ultimately, I'll talk a little bit about that later, but ultimately we have restricted visitation. We've opened them up, but it is a limited amount of time per day that we allow visitation within the hospital amidst the global COVID pandemic. As I said, MountainView's network isn't just about the hospital. It is our physician group as well, which consists of over 120 providers, 38 clinics. That does consist of primary care clinics spread out throughout the region, in addition to subspecialty care clinics. Primary care is everything from internal medicine, family medicine, OBGYN, pediatrics, and then our specialty clinics range from cancer care to orthopedics to palliative care, pulmonology, weight loss, neurosurgery, general surgery, heart and vascular, etc. So lots of specialties, lots of reasons why you don't have to necessarily leave town to get great care. We are investing in the future of Las Cruces, not only through physical infrastructure. We just completed a $25 million expansion of the hospital, which included expansion of the operating rooms, the hybrid room that I spoke about, expansion of the preoperative, postoperative areas within the hospital. That allows us to be more efficient and to provide better access to care for patients seeking surgical services. Incidentally, our expanded PACU space is also equipped to be stood up as an alternative care site for additional ICU rooms if we were to ever need them. Interesting, as we've entered into a global pandemic, it's something nice to have as we look into the future if things do ramp up. We are also a teaching hospital. We teach not only nursing students here, lab students, work with the New Mexico State University and the community college and the medical school, but we also have a graduate medical education program for residents. So we have orthopedic residents here, internal medicine residents here, osteopathic residents here. We believe that the best way to invest in our community and to expand healthcare resources is to grow our own. So grow our own nurses, grow our own doctors, grow our own nurse practitioners, and that's the best way to keep those doctors and keep those healthcare professionals staying in Las Cruces. Um, with that, we have a huge community focus. In part, some of our relationships include the relationship with the school system, the independent school system, for providing athletic trainers to the high school students and to the high school athletic sports programs. Uh, that's some of them right there, taking care of athletes. Of course, sports are canceled this year, but our athletic trainers are still in the school helping them continue to train and stay healthy. In addition, we support various community nonprofits throughout the region, whether it's through the athletic trainer programs for New Mexico State or working with the New Mexico State University or the school district, whether it's the Wall of Heroes for the donor programs, Mavita, the Chamber of Commerce, Border Alliance, Cowboys for Cancers, you name it. If it usually has a healthcare spin on it somewhere, we're usually involved at some point, trying to take the lead in terms of educating folks about the great work, educating and supporting the folks that are healthcare related. So with that, it's a family of people taking care of the citizens of Las Cruces and the surrounding areas. We get a lot of volume that comes in from outlying areas. But this family of 1,500 people, 1,500 staff persons, doctors, nurse practitioners, have really stepped up over the past 8 months through this COVID period. It talks about leading a hospital through change, and that's the end of my of that. I do have some other things I'll share with you, but in terms of like what we've had to do as this pandemic has sort of erupted, we were very early as an organization. So when I say that, in February of this year, February 23rd, we stood up our command center, our incident command center, which is it could be anywhere, but for us it's our boardroom, and we came together with our leadership within the organization and started talking about, hey, what do we need to do as an organization to plan for what is likely to come? Something that's going to impact our community, impact our region on a global scale. And we started taking quick inventory in terms of exercising our disaster management process. And what that is we take inventory of resources, supply chain, staff. We take into account the impact on staff. If schools were to close, how does that impact our staff, right? How does that impact my nursing, my labor force? What is it that we're going to need to do to maybe help provide a safe and secure environment for their families so that they can actually be available to take care of patients? So we were very quick to respond as an organization. No one ever really knows that because those things happen in the boardroom at early in the morning, throughout the day, and late into the evenings. So that command center stood up on February 23rd and was actually stayed in place up until about 2 months ago when we finally stood it down. With that allowed us to get very much ahead of the situation, at least locally. One, we were able to make sure that we had adequate PPE resources for our staff. It made sure that we had an adequate supply chain for things like gowns, just typical things that you wouldn't think you'd run out of, but like hand sanitizer, soap. Some of those things sound very basic, but those are the things that we were all struggling with as a community to find within our local Walmart. So securing our resource supply chain was really important in those early days. And then reaching out and to establish other lifelines in terms of where else we could get those type of resources. Staff, we did actually have a lot of people in the community reach out to us and say, hey, is there anything that we can do for your staff? Anything if they shut the schools down? Can we watch your kids? And can we help stand-up daycares and things like that. We never needed to exercise any of those, but they were all part of our plan. Um, Hospitals are required to have a disaster management plan, and we do. We have one, and we exercise it, and we test it twice a year. Most of the time, we test those sort of in these fictitious sort of these scenarios, but this is the time where Mountain View really had to stand up its plan and exercise it in a real life event. And we did. We the team really did a fantastic job. I can't say enough about the team pulling together on this. Um, Ultimately, what that meant for Mountain View is that we never became overwhelmed. We never became uh, inundated. We never ran out of resources. We never ran out of PPE. We never ran out of out of equipment. We always had a backup B, backup C, backup D plan, and we never, fortunately, we never got to that C level, but we did exercise some of those B plans back to back. So uh, to the point that we really, I think our team was like quite surprised that they never felt sort of inundated. It sort of felt like, okay, this is what we do. We're healthcare professionals. We take care of our people. We take care of our community. Our staff is really important that they feel safe and secure. Um, some of the key things that we did as an organization um, that sort of actually went beyond our walls of our organization were that we started developing policies early and often, and we started figuring out how do we communicate with our medical staff and how do we communicate with our staff in the hospital with the rapidly changing things that information that's coming out of the media, right? So lots of stuff coming out of the media, lots of things coming out of the Department of Health, but it's constantly changing, right? Uh, and so what we did is that we had literally I stood up a daily call for our medical staff that I hosted at 5:30 every day, Monday through Friday, and it was an opportunity for me to say, okay, here's what we're hearing from the Department of Health, here's what the CDC guidelines are today, and here's the new policies or procedures that we've put in place today. So bear in mind that all those could change tomorrow, and they did. Yeah, they did. There were times where I get on the phone the next day and host this call and say, here's the new guidance, and here's the change, and here's what we're doing today. And the mantra for us as a leadership team in the hospital was like, if our staff were complaining that we were changing our minds too much, then we were probably communicating effectively because that's how often things were changing. The guidance and the guidelines around COVID in March, April were changing literally on a daily basis. CDC would change the protocol. Then they change it again. Uh, if you had a staff member test positive, how you trace and how far back you go tracing, all those would constantly change. So we were constantly changing our processes and protocols. So we kept that 5:30 call for the medical staff daily going again up until just a couple of months ago. And then for our staff, we ended up producing what we call a COVID-19 update, and it went out. It actually still goes out. It goes out every day. It used to go out every day, and it was a one memo of all the changes, basically what we talk about on that phone call, and we produce it every day of what was happening within the organization, what was happening in the community, what Department of Health was producing on a daily or weekly basis, and then we produce that on a weekly basis as well as like this huge 5-page memo. Uh, Interesting, that memo still is created today. It's called the COVID recovery memo because now we're focused on more recovering. We need to, as a healthcare organization, it's really important for us to go, look, COVID-19 is not going away. All right, this is something that we're going to have to deal with as a healthcare provider, and we're going to have to learn how to handle it and learn how to take care of patients with it. And it's just part of our reality right now, and maybe forever, right? So this isn't the first time healthcare organizations or systems had to deal with pandemics or global things. But so it's just, this is our new reality. So how are we going to deal with it? And so that's why we've changed the name of the memo to the COVID recovery, or Mountain View recovery. And what that still talks about, it still has the information from the New Mexico Department of Health, the CDC changes, and those are changing. CDC changes still today, changes the way we need to trace, or what an exposure is by definition. The definition of an exposure, I can tell you, has changed probably 20 times. So, but today it's certainly a lot more clear, which we appreciate, and we follow the CDC's guidance. We monitor the CDC, the Mexico Department of Health, and Centers for Medicare and Medicaid websites on a daily basis so that we can change and pivot our process and policy to be in accordance with those leading institutions. So, and we do. So midweek if we have to. So they constantly change. Our staff I think have come used to it and expect that it's like, okay, we're used to the change. We're used to having things pivot on us. We're used to our leadership telling us they're going to change something. And that's good because they go out there and actually look for the information now. So we still push it. We do a lot of pushing, but they actually go look for it. Some of the other things we stood up, Mountain View is, a regional medical center. We do take care of patients from all over southern New Mexico. Think of anything from Socorro, everything in Socorro north goes north, and everything south of Socorro comes this way. And we capture a lot of patients from Artesia, Roswell, Hobbs, Ruidoso, Alamogordo, and these places have good hospitals and good health care systems, but we are the tertiary center for them. Deming, Silver City. So we have a lot of stuff that comes to us. With that, we believed it was important to stand up a weekly call. So I actually have a weekly call every Thursday. It's at 7:30 with every CEO in the southern part of the state. So every CEO of every hospital in the state is invited to this call. About 85% of them get on the call, and we host the call. I host the call. We go over what's happening in our region. What's happening in these other hospitals. Are you inundated? Are you running up low on a resource? Do you need help? How can I help you? It's interesting. We think of ourselves as we're competitors, but at the same time, we're in this together. We're a community of a set of hospitals in the southern part of our state that really need. The only way we're going to get through this is by helping each other out and looking out for our communities in the rural areas. So how can I support the hospital in Deming to help them keep their patients they can take care of and do a great job taking care of those patients. But then when they need me, or when they need the subspecialization of our doctors here in Las Cruces, how do I get that patient to us as quickly as possible, safely as possible, and to take care of them and hopefully get them better going forward. So we host that call is still going on. It's been going on since March or February. And I don't know if it'll ever go away. It's actually opened up the door, I think, in a lot of ways to build better relationships with all the other hospitals in the southern part of the state to help us prepare as a health system, despite being competitors in a lot of senses, but as a health system to take care of our communities. Because at the end of the day, that's why we do what we do. That's why I stayed in healthcare. That's why all 1,500 people in our organization. That's why we're here. It's to take care of our community, to make a difference, and to be impactful in a positive way. So I'm gonna share some other things with you. These are from, let's see, to give you some perspective. Wait, that didn't happen. All right. Get rid of that. Don't save. Sorry, I got too many screens up here. So can you see a
that's
screen
for
a bar graph?
Yeah.
Yeah. So you can see that bar graph. This bar graph is coming. This is the state epidemiology report, and you can actually find this online. Oops. You can find this online on the New Mexico Department of Health website. And so it tells you where we are today. Today, I can tell you that we have more hospitalized patients than we've had since COVID in my hospital, in our hospital today. But those patients aren't necessarily coming from Las Cruces. They're coming from Ruidoso, Roswell, Artesia, all over the southern part of the state. We're seeing a lot more transfers in. So I have more patients in my hospital today, but as a region, we don't. We actually have less hospitalized patients than we did, say, in July. So if you can see my mouse tracking that curve, you can see the 4th of July, that spike. We did see a spike in hospitalized patients and positive patients post-July. A lot of us perceive that to be very much attuned to the interactions with limited social distancing during the 4th of July. And of course, that spike is there. And then it dipped down. And then, of course, we're seeing another spike right there. We're still technically below that 4th of July bar from a hospitalized patients. Like I said, yes, I have more patients in my hospital today that are hospitalized, but not necessarily as a region. What we're seeing is different. Fundamentally, it's a little different. We're seeing younger people test positive more so than older people. So younger folks that presumably aren't social distancing. There's not adhering to that, to all those things that we were doing back maybe a couple of months ago. And that's what we're seeing. So we're seeing more young people test positive than necessarily older folks. Whereas if you go back just in this, May timeframe, that was generally an older population that was testing positive and ending up in the hospital. Now it seems to be more of a younger population that's testing positive. The difference is that we have more people testing positive, right? So I think complacency plays a lot into that. The exhaustion of masking all the time. It's like, I haven't seen my family, I haven't seen my friends. I want to do something. We're humans, and we're social. We're social people. We like to get around. We like to interact with folks. Hey, if we're all introverts, then we wouldn't be seeing anything, right? But we're not. We're not introverts, right? So even introverts. And my brother-in-law, he's an introvert. Best thing ever. He's like, hey, I don't go outside. But even he does like to hang out with his friends. So people are, even the introverts right now are going out there and like, I want to interact, right? So, and that interaction is causing this uptick, and certainly seems to be a little anecdotally, but seems to be being led by the younger population. That said, younger population less likely to be hospitalized, and therefore that hospitalization rate seems to be a little bit lower. The projection does have it spiking up, and I think that's why we've seen the public health order from the governor, reminding folks to social distance, to wear a mask, and to apply those precautions. You can see this map is a little misleading. No, it's not misleading. I try not to pay attention to the colors. And the reason is if you look at the colors, they're darker and the real rates per 100,000 people. You kind of have to keep in mind of the populations within these counties when you apply that sort of methodology of 1 to 100,000. You just have less people, and we're a very big state geographically, but not a lot of people, right? So I think that our state map, when you apply colors to it, it can be a little misleading, but it does tell a story. I want to get to a different screen here for you. Stop sharing. So there's one more. Here we go. and share screen. There we go. Share. So what you should see right now is a line graph. Again, this comes from the state epidemiology report published just last week. This is what you're looking at is the hospitalization rate. All right. So you can see right now we are below where we were that 4th of July, those 4th of July peaks. You know, not to say that I hope it doesn't continue to rise, but right now it is, you know, technically below than what the peaks we've experienced in the past during the pandemic. So we'll see how it plays out, right? Public health order was probably timely. Obviously, you want to give that public health order before you get real high, but we'll see. El Paso, a lot of news media in El Paso, right? So increased positives, increased hospitalizations, ICUs, hospitals at capacity. So what I'll tell you here is a little bit anecdotal. I do speak to a number of CEOs in the El Paso region. We do keep in touch, in part a lot of reasons because of how do we work together from a disaster management perspective and from a beds capacity perspective. Those things are important. Yes, they are seeing positives. Yes, but it's similar to us. A lot of young folks, more younger folks than older folks that are positive. Younger folks that are positive but aren't necessarily hospitalized. Lots of asymptomatic positives that never become symptomatic and never get hospitalized. So they're seeing a lot of that. The ICU capacity, I think it was on one of the news outlets, you know, talking about ICU capacity in El Paso. One of the things that is impacting the labor force in hospitals is the impact of schools being on not in teleconferencing, you know, schools. So no in-person schools. So we've seen this. We've seen turnover in our labor force, but not turnover because I don't want to work because of COVID or I don't want to do this. The turnover we've seen that's been the most impactful is we have a fairly young workforce that have children, and if those children are having to do school at home, and they're originally I'm from Connecticut, and my family's up in Connecticut, and I'm in Las Cruces because I love being here in southern New Mexico, but I have no familiar support, and without that support, it's really hard to do stay-at-home schooling. When you're a healthcare professional, or any professional for that matter. So we're seeing our members of our labor force having to make decisions to move back home, where they have a family infrastructure or support system around them to so that they can actually go to work, right? It's not uncommon, as I was talking to my CEO call, it's like, we hear nurses that it's like, man, I'm working during the day. I'm working at night, but then I'm not sleeping during the day because I got to get my kid on Zoom for their class, and I get an hour here, an hour there, and they're just coming to work exhausted. And, well, yeah, with schools being out or stay-at-home schooling, right, that has probably had the biggest impact on our labor force as a healthcare system. And I just suspect that as a healthcare systems are not alone in this. It's everybody is having a huge negative impact on our labor force. It's like they just can't do two things at one time, right? And if my children have to stay home, then I got to stay home with them to make sure they get on Zoom, especially if they're not. I mean, if teenagers may be okay, but I mean, if you're talking 9-year-olds, or my children are 3 and 5, right? There's no way. That's not happening. Tell a 3-year-old to log onto a computer, right? Okay. So that dynamic of people just having to make sure they have family support around them to help with the online learning is causing people to uproot, right? I love living in southern New Mexico. I love living in El Paso. I love living in this region, but I gotta go home. I gotta go back and maybe move back to where my parents are, or I gotta go back and move back to my husband's parents are, or wherever it is, so that way I have some sort of support and can keep working. Now, for healthcare professionals, this is a double-edged sword. Healthcare professionals can literally get a job anywhere. So a nurse can leave Mountain View, drive to Phoenix, and she'll have a job. He or she will have a job within a minute. So seconds. Before they could probably apply online while they're driving, they'll have a job as soon as they land there. And that goes for lab techs, rad techs, you name it. Name your profession within our organization, and you literally are extremely mobile from a professional standpoint and an employment standpoint. So when it comes to like, oh, well, I need to move, but I need to find a job. Finding a job isn't even a thought process. It's like, I'll have a job. As long as there's a hospital there or a health system there, I'll have a job. I just need to go back and have, move with my sister, so maybe we can help together, or move with my parents, by my parents, or close to my parents where I have some support. So that labor force impact is what's hampering the bed capacity, if you will, right? I spoke about that $25 million project we did for our expansion of our operating rooms, and it added that this post-acute care, post-operative care suite, which also can be expanded into surge ICU beds. It's like 21 ICU beds that I could add. But if I don't have the labor force, if I don't have the nurses, if I don't have the healthcare team, it's really just a bunch of beds. So that labor force caveat is when I talk to folks, other CEOs and other health systems in our region, both El Paso, Las Cruces, and southern New Mexico, it's the labor force piece that's really impacting our bed capacity. It's not that I couldn't. I have 23 ICU beds in our hospital today that are built as ICU beds, and I can stand up another 21, but I can't stand them up because I don't have the nurses. Now that said, we're bringing in contract labor, and we have a surge plan on to expand our capabilities. So I could probably stand up another 8, no problem. Well, I wouldn't say no problem, with a lot of hard work and extra effort and planning. But the whole region, we're seeing a shift of healthcare workers move, and so that there helps. Those things, there's pros and cons, right? Hopefully, maybe there's some ICU nurses from Las Cruces that are living in Phoenix or San Diego, and they're like, oh, I'm going to move back to Las Cruces. We've definitely hired some nurses recently because of that. It's like, I'm leaving. Where have you been? I'm in Seattle. Why are you coming here? It's like, my parents live here. I'm coming back to Las Cruces because I can't do online learning, right? So it's a very familiar story. So I know it's 2:39. I've given you a lot of information. I've been talking for 40 minutes. So I'd like to give you some time to answer and ask any questions. I'm sure they're out there. So any questions or anything I can answer for you?
Okay, anybody want a comment or a question? Yeah, go ahead, Carla. Yeah, go ahead. You got to unmute yourself. Carla?
Yes, thank you for the talk. I know you talked, I was just wondering about your preparations for a possible resurgence of the COVID in the fall and winter of this year. You talked about the 21 bed potential to expand, but I've just wondered, would you bring back the command center? What else might you do, should there be a very large resurgence?
Yeah, no, great question. We've actually already restood up our command center. So our command center was restood up. So in the original phase of this, we developed certain policies and processes, a lot of which have ironically been adopted by other hospitals throughout our region. One was thresholds of when we would restand our command center back up. That for us us at 10, then we're going to meet, we'll call it back together, we'll meet, evaluate the situation, and then when we hit 12 is when we would restand it up on a more permanent structure. So we actually, our command center meets on Tuesdays and Thursdays at 7 a.m. in the morning, where we make sure we're going down our list, resources, availability, any changes, any changes that require immediate changes in process, policy, or protocol regarding from CDC, CMS, et cetera. And it's just a reevaluation of the situation. So a sit rep, if you will, for anybody in the military, right? So, so we do that on Tuesdays and Thursdays every week. Now that said, if what's happened as a result of that restand up. So originally we had an 8-bed isolated COVID unit. So it has a separate wall and it's on a separate HVAC system. And all our units have HEPA filters and stuff in the air ducts that we change out on a regular basis. But this unit, we could isolate completely. We've actually changed that. That's now, we've moved the temporary wall. Now we have a 12-bed med-surg unit for COVID because of the increased volume. Same thing with our ICU. We have dedicated 8 ICU beds that are dedicated for COVID. So that's the COVID side, and this is the regular side. Try to keep our patients separated. With that, as with thresholds go up, the command center will make the decision. They don't even need me to make that decision. So they have authority to where we could turn our entire 3rd floor, which is 50 beds, into an entire COVID unit. So we've already hit sort of like thresholds. So as thresholds hit, we've already developed plans to implement and move to the next stage. We're at 18 today. So depending on how that plays out, and by Wednesday, we could end up sealing another hallway if that spike continues to go up. It's meant to be flexible. All our leaders within the organization are actually trained on the incident command system, which is developed out of California during earthquakes and whatnot. They actually go through, all our leaders from director or manager and above go through that training. So it's training specifically from FEMA, and it's called Incident Command Systems, and it's like 20 hours of training. So, and then we test it twice a year. The reality right now is like we don't need to test it because we're living it. We're living our Incident Command System right now. So, in addition, policies. We've already, 8 months ago or 7 months ago or February, we didn't really have policies on visitation. Our visitation policy was that we allow visitation and we encourage it. We want people in our hospital. We want families involved in healthcare. So our visitation was, we allow visitation. It was pretty as simple as that. It was one page. Now we actually have a very lengthy, exhaustive visitation policy, and it has 5 phases of visitation. 0 visitation allowed, partial visitation allowed, extended hours visitation on the weekends, and so it goes through, from 0 visitation to, where we used to be pre-COVID, and has various. So right now we sit in phase 3 visitation, which is we allow visitation 4 to 8, 7 days a week throughout the hospital, only 1 visitor at a time. It doesn't have to be designated except in the ICU. In the ICU, it has to be a designated visitor. We don't want a lot of traffic in the ICU. And so that's what our visitation, that's phase 3 for us right now. That phasing process was actually adopted by several hospitals in the southern part of the state. Again, a lot of collaboration between the health systems in the state in terms of, hey, what's working for you? What are you doing? What are you not doing? We are one of the few hospitals that kept our visitation open, at least in phase 3. A lot of hospitals have shut it completely down. I'm often asked why. The reason our team's decided to keep visitation is that we have found that we believe it's very important to have families involved in healthcare. And what we noticed is that when we didn't have visitation during that 3-4 month period, is that we had a lot of problems with discharging patients, and we weren't quite sure. It's like the average age of our patients in the mid to late 60s. So sometimes you got some, confusion happen, and we really need to have families involved in healthcare. And then once we opened that visitation, we saw those complaints go down. We also saw less people coming back to our hospital because they didn't understand what was going on, or didn't understand their discharge instructions or the medications, or they didn't get the medications. Once we opened that visitation, we saw all those things improve, right? So the readmissions improved, people not coming back to the hospital because they didn't get the instructions or didn't understand. We adhere to the screening processes, and yes, we ask visitors, like, no, you have to wear the mask in the room, you have to wear the mask in the hospital. No, I'm sorry, you can't go to the cafeteria. You can't wait and hang out in the lobby areas. Yeah, we have a lot of rules, and it's kind of like running hospitals 15, 20 years ago because 15, 20 years ago, we had a lot of restrictions around visitation, and then we got rid of them all. And so I have a lot of older healthcare people, executives and nurses like myself that have been in the business for 25 years, and we remember that time. And I got a lot of young folks that, like, they have no idea. They're like, what? Like, they're not used to it. Like, this is a whole new world for them. So it's tough. I do think that we will keep visitation open for as long as possible because we think that it is very important to the wellness of a person and getting them better sooner. That said, will we go back? Could we end up going back to phase 1 with absolutely zero visitation? I think that's possible, but that would pretty much mean that the hospital systems the bed capacities are full and overwhelmed with COVID. So I've had colleagues that in Texas where he's like, Derrick, I got 180 COVID patients in my hospital. And I'm like, that's a different story, right? So we do not allow visitation in COVID units. So in phase 3, if you are COVID positive, we do not let visitors go into the COVID areas, mainly because the confidence of donning and doffing all the protective stuff, that's just not something that we want to take a risk with anybody. We did deploy iPads. I think I have 12 more coming on their way, but we have iPads, so we want to leverage technology so we can do FaceTime with patients. They can FaceTime their family. We have these little phone holders that detach to the bed, and someone could have it. You can hold their phone in front of them so they can FaceTime and see their family, things like that. So we've gotten creative. It's not perfect. It's never going to be perfect, but we're trying to leverage technology as much as possible, and then do the best we can. So, did I answer your question, Carl?
Yeah, Jack, you want to ask a question?
Yes, thank you very much for your presentation. I would like to make a comment on the new hospital that opened up on North Main. I believe it's called Three Crosses. I attended several neighborhood meetings when that was in the early stages, and a lot of people were opposed because it was called a boutique hospital. They would only take people with the best insurance and those specialties that paid pretty well, such as cardiology and orthopedics. They would not have obstetrics, which is not a moneymaker. So, and that would take some of the good patients away from the other two hospitals, and they viewed it as a negative thing for our community. You have any comments about the hospital?
I mean, it's not uncommon to have hospitals open up. So it's not my first rodeo, if you will. I've been in communities where other hospitals have opened up. This Three Crosses is a hospital that does have physician investment, and that's one of the reasons why it's the developer got a bunch of physicians together, and it's an investment, right? Opportunity for them. It's not surprising that they're not taking all insurances, and it's not surprising that they're only focusing on high margin types of healthcare. That's usually what they do. Do I see it as a threat? I mean, obviously, it's a competitive threat. It does have the potential to take volume away from us. It could take good volume from us, which could hurt us. But there is a reality. It can't take all the volume. One, it's not that big. It's only 32 beds, and it's only got 10 ICU beds, and its ER, I think, has 6 rooms. So it was not built for any sort of real volume. And as you mentioned, it doesn't do obstetrical care. So yes, could it hurt us? Sure. Will it? What I tell my team is, like, we need to be the easy button for our community, and we need to focus on our quality and focus on how we deliver healthcare and our service, and our community will choose us. So let's do all the things like, how did we become the market leader in Las Cruces in 16 years? It's because we focused on the right things. We're going to do the right things for our community. We're going to focus on providing good quality service-oriented healthcare. And if our community trusts us, they'll come to us, right? Not to say that we don't get it right every time. We get our fair share of grievances. They're down 70% from last year, which we're very happy of. But we still have grievances. What's important is that we learn from them. Important is that we call the patient back up, understand where we may have gone wrong, and it's really important that we bring that back, because usually it always comes down to communication every time. If I can find out where we were wrong, usually I can find the staff member that maybe that interaction wasn't optimal. It's really important that we share that information, feedback with the doctor, with the staff member, and not in a punitive way. Let me be clear. This isn't about, firing somebody, or it's about, hey, Carla, it's like this interaction you had with this patient, it's like it wasn't optimal. It's like they didn't feel this. I know it's not what you meant to come across, but they didn't get it, right? They didn't understand what you were saying. They felt that you were dismissive. They felt X, Y, Z, right? So now, hey, look, you're in an ER. You interact with over, 30 patients a day. And this is one patient that had this interaction that they didn't feel went great or that wasn't optimal. So think about it. Maybe you remember it. Maybe you don't. It's interesting. Most staff remember when they didn't feel right. They're like, oh, I remember that. It's like, yeah, it wasn't, nothing was going right, right? Everything was going wrong, and the patient felt the same way, right? It's about how they can change their behavior, pick up on the nuances next time, and maybe change their approach. Or sometimes it's like, get a team member, right? So hey, Jack, this isn't working. I'm struggling with this patient. I need help, right? Get a team member, get some help. I truly believe that healthcare provides, there's no one at MountainView that stays, that works in healthcare because they want to do wrong or because they want to make people miserable. They're all in it because they want to make a difference and want to help people get better, and they want to turn a frown upside down, if you will. I know that's silly, but because if this healthcare is too hard, there's so many other things easier to do than to do healthcare, right? It's too hard. We're working with people usually in their most challenging times, and if you're not really focused on for the right reasons, this isn't going to be a career you're going to stay in very long, just because it's going to wear on you. Now that said, hey, when I have constant feedback that's negative about an individual or doctor or whoever it is, then yeah, we will take appropriate action. And sometimes the fit isn't right. And have we moved people on because they are not operating and focused on the standard of care that we feel is where we need to be as an organization and what our community deserves, mind you, what our community deserves, then hey, we'll move them on. So am I worried about 3 Crosses? I know that took a long sidestep on that one. Not really.
Carol, you had a comment or question?
Yes, both. You have a very popular program called Senior Amigos, and about 1,600 people are very anxious to have it open again. But I'm wondering about what is the Rio Grande Medical Plaza? It seems like a lot of Mountain View doctors have moved there. Is that all Mountain View or not?
Yeah, Rio Grande Medical Group is now part of Mountain View Medical Group. Rio Grande Medical Group was an independent group of doctors for a very long time, well-established group. In 2018, they joined Mountain View Medical Group, and we kept the name as part of Mountain View, but they are very much part of Mountain View Medical Group. Dr. Samuels, Rosales, there's 30 of them. So, I mean, we have a number of physicians. The name we kept because of people identified with it. So it does say affiliate of Mountain View. I think in time you'll see that sort of merge together and it'll just say Mountain View Medical Group. But they are very much part of us now. Our campus now, which consists of 5 buildings, if you will, on the main campus, the hospital being number 1. We have a wound care center up on the hill, which is number 2. Building 3 is it looks attached, but it's not attached, but it's a large medical office building. It has most of the specialists. So if you're a surgeon or a proceduralist, that's where they're at. And then buildings 4 and 5, 4 being the Rio Grande Medical Group, was the Rio Grande Medical Group, is really now focused on primary care. And then building 5 is pediatrics. Yes, Rio Grande, the reason the name will probably sort of eventually dissipate is just because as we've moved our specialist into one building and our primary care into another building, all those doctors sort of got mixed up. And so now everybody, after almost 2 years of integrating them into us, now everybody sort of identifies themselves with Mountain View Medical Group.
I'd like to ask one question in regard to, I noticed back in spring and early summer that there wasn't quite as much activity around the hospital. And I just wondered how much, selective surgery and things that you don't have to do, how has that changed during the COVID period?
Well, so we were doing, as I said, we were up Mountain View and our team were very proactive in terms of managing our resources up front. So we didn't experience the lack of resources to do surgical procedures or elective procedures early on. So when the governor mandated that no elective procedures were allowed, that's when we stopped. So she said, hey, no elective procedures starting Friday. We're like, okay, we let surgeons schedule up to Friday, and then that was it. So a lot of our volume decline, bear in mind, so we average about 1,300 surgeries a month normally. And during those months when elective procedures were, by executive order of the governor, were not allowed to happen, we only did about 200 surgeries. And when you think about our imaging, like 20, or again, my numbers are going. Let's start with ER. ER, emergency room, we see about, oh man, now I need a calculator. 50,000 by 12.
It affects everything, right?
Yeah, so we saw, a lot less emergency room visits because people just stopped going to the emergency room. The ER is still down about 15% from prior year. Came down 90%. The odd thing with healthcare and hospitals, the economic engine, the way the finances are with hospitals, it's the elective stuff and the ancillary things that really pay for everything else, right? So everything else is paid by those things. Those other things we lose money on. So it was significantly financially impactful to every hospital in our state when elective procedures were taken away. That said,
are you getting back more to normal now?
Yeah, so great question. We are, because we were, if you've probably heard several times, that we've always been a very proactive team. And when I say team, it's not just myself and my leadership team, but it's also my physician leaders within the hospital. So my medical executive committee, my chairs of each of the surgery department, my chair of the medicine department. We have always been a very proactive team throughout this entire event, and we remain so. So even before the governor had released us to go back to elective procedures, we had already started working up a plan on how would we get back to doing elective procedures safely, right? Bear in mind that we need to make sure that that staff can be masked, that patients can be masked, that we have the resources, we have the hand sanitizer, we have the equipment, we have the PPE, the personal protective stuff. And then how would we phase that in appropriately? And then how do we test, right? Do we test? The first answer to the question, do we test everybody? Then the question is, do we have the resources to test everybody? And how would we test everybody? And what's the turnaround time? So and of course, common language, right? Phases. We had phase 1, 2, and 3, right? So phase 1, no elective surgery at all. It's only emergencies and urgencies. Phase 2 would be elective procedures that don't require an overnight stay at the hospital. And then phase 3 would be all procedures, everything, right? So we developed that prior to the governor lifting her order. So it was interesting. Our team anticipated the governor lifting that order, and we just didn't know when. So we picked a date out in advance, and we were like, I think it's going to be this day. And so we told all our surgeons, we're like, okay, we're going to let you go into phase 2. But bear in mind, if the governor says no, it's not happening. So everybody took a little gamble on that, and we had a lot of patients that are like, look, I just want to get my surgery done, right? Patients want to get their stuff done, right? I've been planning for this for months, sometimes years, right? Some people sit on gallbladders for years and are like, all right, fine, I want to get it done. We were out of the gate very quickly in terms of getting back to elective procedures. Bear in mind, we felt very comfortable about that because we had established protocols and processes, made sure we had the resource capability. I can tell you how many days an N95 mask I have available on hand at any given moment. And so we were very comfortable to line that up. So when the governor released it, we already had stuff scheduled. So we have actually last month, the month of September, we were ahead of prior year on elective surgeries. Oh. And then ahead of prior year on cardiac catheterizations, elective cardiac procedures. We were ahead of prior year on a number of ancillary and outpatient procedures. That's the only thing that we were behind from prior year was the emergency room visits, where we were down about 15 to 20% from people visiting the emergency room. You know what? That may be a good thing. Reality. A lot of people use the ER for stuff that really, that's a really expensive way to handle that. So that maybe there's some, you look for the silver linings in times like this. So maybe people are using their primary care doctor or an urgent care setting or a walk-in clinic as opposed to just coming to the ER for a sinus infection. I
see Sarah's come on. We've about run out of an hour, right, Sarah?
Yeah, so we went a little bit over, so it's about 3:05 now.
But that's fine. Well, we really thank you, Derrick, for doing a fabulous job. That was
Thank you.
Very good. Very good.
Thank you for the opportunity, and I like doing these things. I like educating and communicating and talking and hearing guys. So anytime.
So next week we're going to have Professor Susan Spice. She's from the Department of Government at the university. She's going to talk about the difference between capitalism and socialism and other isms, and which is a big topic these days. So that should be an interesting roundtable. So that will be next week at 2 o'clock.